Welcome, everyone. This is Liza Greenberg with the Patient-Centered Primary Care Collaborative Support and Alignment Network, and we are delighted to have you joining in the third of our Learning Network calls on adopting person and family engagement strategies to improve pediatric asthma care. As you know, we are focusing in on both the quality improvement strategies for addressing pediatric asthma and also layering on person and family engagement techniques that have been identified through the Transforming Clinical Practice initiative from CMS. So on today's call, we have Ruth Gabernick, who is our faculty member and pediatric quality improvement expert. We also have a practice innovator, Lucy Mauric, from Children's Hospital of Orange County, or CHOC Practice Transformation Network, and Ruth will introduce her in more detail later, and myself, Liza Greenberg, with the Support and Alignment Network. And since this is the third call, I won't spend much time on these intro slides, but just to let you know, a reminder that our goal here is to reduce hospital admissions for asthma by improving quality of care, emphasizing PFE strategies. Today's goals, we will look at some of the strategies used by CHOC to reduce asthma admissions or readmissions through their PTNs, quality improvement activities. We'll focus in on some of the metrics around person and family engagement, specifically this time looking at shared decision-making tactics, and then identify a number of resources. And just as a reminder, the resources are posted on our TCPI website, which all of you should have that link that was on the registration page and has also been in a number of the reminder emails. But if for any reason you're having trouble finding the resource links or finding the recording link, please let me know. I also wanted to remind you that if you do want to talk, and we're hoping that you all will have a chance to chime in on today's call, we want to make this as interactive as possible, you do need to have used your PIN code when you dialed in. So if by chance you dialed in and just pressed pound, didn't put in a PIN code, if you could just hang up the telephone part and redial in and get that PIN code, then you'll be able to talk. So let's see. So these are the person and family engagement metrics that have been identified through the CMS Transforming Clinical Practice initiative. We're focusing on these ones in the middle: shared decision-making, patient activation, health literacy, with the point being that these strategies are all tactics for engaging patients and particularly in pediatrics, their family members, that will help get better outcomes for whatever clinical quality improvement strategies you're using, such as care planning or registries or medication management. So it's all kind of a layered approach. And once again, kind of showing this schematic, which you've seen before, that the techniques really focus or help you work through the care algorithms that you're already intending to do. So if you're diagnosing asthma, you can use PFE techniques to really do a better job of it, to make sure you've got patients returning for follow-up visits, improving word of mouth, which actually is a business improvement that helps the organization. So the point being that these are activities that should augment the work you're already doing, not separate areas of performance that you'll be working on. And so with that intro, I'll turn it over to Ruth. And Ruth, do you want to take us through the rest of the call?
Sure. Thanks, Liza. Good afternoon, everybody. Nice to meet with you again, our third lesson. And you've seen this slide before, a reminder of the ARC definition of patient and family engagement, and the fact that we're talking about the need for patients and families to be actively engaged at all levels of their health care, including pediatric primary care, and the need to ensure free flow of information to and from the patient and the environment where the patients and their families are being, where they're being treated with respect on an ongoing basis. So next slide, please. We're really very lucky to have with us this afternoon one of the leaders of a practice transformation network. I'd like to welcome and introduce Dr. Lucy Mauric. As Liza said, she's with the Children's Hospital of Orange County and is the manager of the Population Health Quality and the Southwest Pediatric Practice Transformation Network in Orange, California. And Lucy's going to share with us information about the progress that in reducing emergency department visits for asthma that she and her colleagues have been working on. So Lucy, it's all yours.
Thank you, Ruth. I appreciate the introduction, and thank you for inviting me. And on behalf of CHOC, we're very appreciative of this opportunity to share our knowledge. So if you could just advance the slide. So I wanted to share with everybody just what we've been able to accomplish with regards to ED utilization. This slide represents our improvements from the Q1 of 2015 to Q1 of 2016, and how we were able to reduce our ED utilization as it relates to asthma from 3.8% to 2.10%. So we had a significant drop in ED utilization as it relates to asthma, and with that we've how we've been able to do that is with a lot of help from our quality improvement advisors who've been out in the field with educating the parents and educating the practice managers and the doctors on asthma in particular. So if I can go ahead and give you a little bit of background, our data came from claims, and we have approximately 234 practices in our PTN. So that includes a capitated population of about 230,000 children, 18,000 approximately of which were children with asthma. So our projected year-over-year reduction in ED use is about 46%. So we expect to have about 1 million in potential savings. So we hope to stay on track with that. And then with that, I wanted to share with you how we were able to do that. So if we can advance to the next slide. So I put together a little driver diagram. Our aim was to decrease asthma ED visits. And with our primary drivers, we thought, well, the best way to do it is to obviously educate the providers and staff out in the community. So we provided them with asthma clinical care guidelines, and we were able to take those guidelines and embed them in multiple EMRs within the community so that the doctors would have easy access to a guide on how to manage the care of their asthma patients. We also provided them with paper copies of those guidelines. They were laminated, and we noticed quite a few of the practices were using them even as a laminated format by the office manager putting the laminated copy with the paper chart or with the paperwork before the doctor goes in to see the patient. So it was very effective in the education process. With the next item that we chose was the practice use of the asthma action plan. This was critical. All the practices used, well, not, I shouldn't say all the practices, most of the practices used asthma action plans as a guide for their patients. And it was kind of a collaborative thing with the patient and the doctor. So they worked together to create these realistic asthma action plans for the patient. We provided patient education via pamphlets and more geared towards the education level of the parents, because we do have some lower income families that have education levels that are lower than you might say some other areas of our population. We provided risk stratification tools. We created a pediatric risk stratification tool for any of our patients that were seeing the ED multiple times over a short period of time. And that's proven very effective also with the practices. We allowed them to refer to we educated them on referring to a specialist. We have what's called a breath mobile, which is a mobile van that would go out to the local community schools and community centers, and they would just park there in the parking lot, and appointments were made and the patients would show up there at the school. So it was very effective in decreasing the usage of the ED because they had immediate access right there at the school or in their local area. We had specific asthma ED utilization lists that we brought to our doctors. So there are variance curves on how many times their patients went to the ED in relation to their local pediatrician, so their competitors in the area. So we took their data and we compared it and told them, you know, this is where you are and this is where the rest of the community is at, and there's room for improvement, or you're doing really well, and we would give them levels of encouragement or, you know, praise if needed. So that was also very effective. And then what we're doing also is going back and touching base with those practices that had were a little bit challenged in the area of ED utilization. So once we provided them more technical assistance, we went back and are showing them how much improvement they've made over time. So we've also used practice asthma registries, which has also proven very helpful because we're able to identify and monitor the patients with asthma. So we can always look back and pull data from those asthma registries. And as I mentioned earlier, the asthma action plans are critical because that involves the patient as well as the doctor in coming up with a plan of care. So that's it.
That's great. Thanks, Lucy.
You're very welcome.
I have a few questions. Your comments about the asthma action plan is appreciated because we're going to talk about that today. And I love the fact that you used the asthma utilization list so that practices could see how their ED use compared with others. A little competition, you know, can go a long way. So I think that was a interesting approach to motivation. Were you able to, as part of your process, also get feedback from patients and families as you were working on this process? Were they part of the discussion of how things were rolled out or the impact on them?
Yes. So with regards to the care plans, we do have a family advisory committee that we run things by before we roll them out. So we meet with this family advisory committee, which consists of parents that have chronically ill children. And they're not all asthma, they have varying conditions. So we meet with them once a month, and whenever we roll something out to a practice, we always run it by them to see what their input is. So yes, we did get parents' responses with that, and we did make corrections and modifications to the things that we rolled out to the practitioners based on their comments.
Great. Thanks for sharing that. And one more question about the asthma registry. Do you find that is it an electronic version of a registry? Is it one you provided or an Excel spreadsheet? What was was it kind of a standard registry that you shared with everybody?
Right. So some of our practices do not have EMRs, so they do have to use the Excel spreadsheet. And so that's obviously one of the easier routes to someone who doesn't have an EMR. But most of the practices have it embedded in their EMR, so it's electronic. They're able to flag them.
Okay, thanks. And I like you had different formats for your education to make sure that you were reaching everybody with electronic or printed and, good strategy. So, any questions? I'm sorry?
No, that's okay. Go ahead.
No, go ahead. No, I was just going to see if there were any questions from other members of other participants, whether they want to, if they can be unmuted or if they can type in a question in the chat box for Lucy. Okay, don't see that there are any, but if you do have any, please, we can come back to that or get, or get it to Lucy after the call.
Yes,
So
and Ruth, if I can also mention that if anybody wants any of our resources or would like information, they're welcome to email me.
Oh, that's great. Thank you so much for that.
You're welcome. I'll put my email address in the chat box.
Okay, that would be appreciated. Thanks. Okay. So if there aren't any other questions for Lucy, I would like to take a minute to just kind of come back to one of the action items that we talked about last month, and the review and use, the testing of the teach-back method with the next patient that you saw after the learning network call last month. If you could give us a little feedback about how did it go? Any comments, or did anybody get a chance to test it with one patient? I'd be curious to hear if you're,
Ruth, I saw a message that Diane Weiss has a question. Diane, I don't know if you're unmuted, but do you want to give it a try?
Yeah, I don't see questions on my panel thing here. Diane, can we hear you?
Yes. Can you hear me?
Oh, great.
Hi, Ruth.
Great.
How are you?
Good. How are you?
I was curious to find out if we could have access to a copy of those asthma clinical care guidelines that were referred to. I'd love to see how they compare to the ones we're using.
Absolutely, Ruth. Just go ahead and send me an email, and I will forward that over to you.
Alrighty, and the email is going to be displayed somewhere, or am I missing it somewhere?
I put it in a chat box.
And I don't think I'm seeing it, but I'm going to try.
If you don't see it, we'll make sure after the call that it's sent out to everybody.
All right. Thanks so much.
Sure. Thank you. Okay. Did anybody want to share anything about their use of testing the teach-back? If not, we'll move forward with today's topic. Okay. If I could have the next slide then, please. Okay, so today let's focus, we're going to continue our discussion on improving asthma care management and focus specifically on shared decision making. And this definition is from the SHARE approach that's been developed by ARC. And really the idea is that it's focusing on decision making. It occurs when the provider and the patient and family are working together to make the best healthcare decision for that patient. With the optimal decision taking into account, remember that evidence-based information and about what the available options are, the provider's knowledge and experience, and the patient's and family's values and preferences. So on the next slide, if any of you are not aware of the SHARE approach, this is a nice model, very simple. We have this resource available. It's posted on on our project website, the TCPI website, and you can access it after the call and share it and discuss it with your team members. But it really is about seeking your patient and family's participation and being able to really help them explore and compare the different treatment options, and to take into account as part of that their values and preferences so that you reach a decision in collaboration with everybody, who the patient, the parent or caregiver, and the provider. And as part of that, then once a decision has been made, to evaluate the decision that's been reached. And as part of that, again, just to remind you, it's always an opportunity to ask your patients and parent and caregiver for feedback about even the process of testing this use of shared decision making, to say at the end of the visit, so, I'm doing something a little differently today. How did this work for you? and get their feedback. And they'll be happy to tell you what worked and what didn't work. On the next slide, this slide talks about the shared decision-making with children. And there are a few factors that it's really important to take into account when you're doing shared decision-making with pediatric patients, having to do with the competence of the children based on their age and their abilities, and the family's oriented perspective, so that it doesn't undermine that parent and child relationship, but that you're taking into account motivation of the child in making decisions for his or her health management, and also, in addition to that, the parental attitudes and beliefs about the child's involvement in the healthcare decisions. These thoughts, these factors are discussed in a great article that is also posted on our project website about shared decision-making in school-age children with asthma, specifically with asthma. It has some great information in it, and again, I would encourage you to download it, read it, and share it with your team so that you can have a discussion as you're moving forward to think about how to do shared decision-making with your patients. Because on the next slide, you see that what this is about is the idea of changing the diactic interactions between the provider and the parent into triactic interactions, so that it includes the provider, the parent or caregiver, and the child in the opportunity to work to improve the child's asthma management. This has been reported to also enhance the child's self-confidence, as well as improve those self-management skills. As I said, it does require assessing child's competence, and also the use of some specific communication techniques that are discussed in this article. There's a nice description about the use of visual aids, turn taking, clarifying communication, and role modeling. Opportunities to take any one of these communication techniques and say, okay, I'm going to test the use of this with the next adolescent patient or school-age patient that I see with asthma in my office. It also gives you some good strategies for parents on how to provide information about asthma and treatments based on a child's questions and their interests, so that can continue outside of your office and the parent feels supported. Next slide, please. So this all kind of comes into play, it falls in line with what we discussed last month, and the need for careful listening, inquiring about at-home management, nonverbal attention, interactive conversation, tailoring short-term goals and long-term therapeutic plans that will foster that patient, provider, and parent relationship. And remember that these communication needs are needed by the provider to be able to have the targeted information to help guide those discussions. Next slide, please. In general, care plan goals, here's a list of them. They can be for any type of care planning, but the important thing to keep in mind that this is team-based care. And it's important that you're all on the working and thinking about and working with the same care plan, whether it's for the care coordination, whether you're looking at and discussing shared goals and communication within the team, including the patient and the parents and caregivers, or between teams, also with specialty teams and primary care. And these plans may be printed out and given to a patient. They may be made available on the patient portal. They may, in the case of asthma, remember it's also important to share them with the schools and with the specialty care practices that are also co-managing your patients with asthma. Next slide, please. And just continuing the idea, here's another example of a general care or action plan, and thinking about the fact that when your goals for an asthma care plan, there are examples that you need to keep in mind that would be patient goals, They may be family goals that you want to consider, provider goals, or care coordinator goals. So when you're having this conversation, the goal planning takes place on several levels, but it's that interaction and dialogue and among all of the care, the team members, including the patient and caregiver, that are so important to make this really work. Next slide. Keep in mind, this is great. We're in an age where the electronic health records and computerized decision support tools should be integrated whenever possible into the patient visit, because it really allows, it helps facilitate communication and shared decision making. I know that there are still teams that are working on paper and not don't have access to an electronic medical record, but even to be able to take these type of questions and create, and have that conversation with paper forms or a spreadsheet. There are opportunities to be able to use these questions in that way, to be able to identify the challenges, the strengths and supports, the action plan, and some of the things that how does the patient feel or the family feel? How confident do they feel that they'll be able to follow that plan that you've developed together. Next slide. So here are some key features specifically of an asthma action plan. All the people who have asthma should receive, remember, they should receive a written asthma action plan to guide their self-management efforts. These written plans, as you see in this example, should be keyed to symptoms, severity, and control, and should include information about daily management, as well as early recognition and action for exacerbations. You can see here as an example, medication names, whether they're trade or generic medications, information about how much to take and when to take it, how to adjust medicines at home and or at school as the symptoms may change. And these asthma action plans, just like any other type of chronic care document, are created or should be created as a result of that shared decision making, because it provides a list of the daily and emergency medications, the asthma triggers for the patient, and provider contact information. It helps the patients and family members with asthma self-management. It should, as I can't emphasize enough the need for it to be generated in partnership, in a three-way partnership, and written in the room with input. So it's created not before or not after the patient and family leave, but it's actually can be created in the room with them. Once it's created, it's the chance to review it and use it for education. And just a reminder that then this is where your teach back method can be used to allow that patient or family member to tell you back in their own words what you just explained to them. So if you haven't had a chance yet to share, to test the use of teach back, again, this month, you have that opportunity with the use of an asthma action plan. Next slide, please. So this asthma action plan is actually one that we've been using broadly in New Jersey. It's a fillable PDF. It can be, as you can see at the bottom, it can be saved. It can be printed. There's an opportunity to print the medicines only. It's available in English and Spanish. And so you may find if you Google your state's asthma coalition or your organization, a community-based organization, you may find that if you don't already know about one, I have a feeling probably the schools have shared this type of plan with you, because this is exactly what they want for any of your patients that have been diagnosed with asthma. So as opposed to just having a one that you have to write out by hand like the previous one, this one is kind of a step forward. Even if you don't have an electronic health record, you could use a fillable PDF. There's also now, there are interactive asthma action plans that you can use the shared decision-making process for to be able to create that plan in conjunction with the patients and families. On the next slide, this is an example of one that is from the Minnesota Department of Health. It can be downloaded as a desktop version or as a network version that can be integrated or linked with an electronic health record. These type of, and this one, this interactive asthma action plan, or an IAP as it's known, is available free. And you can see that there's a link on this slide so that you can get some additional information if this is something that you may want to test. Now remember, this is quality improvement that you're doing as part of, for this transformation work. So it's not about just, implementing a change and saying tomorrow, okay, we're all going to use this new electronic interactive asthma action plan. But the idea is to have one of you in your practice test using it with the next few patients that you may see, and then share with everybody what the experience was. It's whether it's this type of electronic plan or a fillable plan, remember that the most important part of this is not the plan, but the process, and that you are working together as a team with the patient and the family to do this work. Next slide, please. Just a reminder, as part of that asthma care visit, remember to have a team member, make sure that you teach families, patients and families, and demonstrate the correct use of their devices, spacers, nebulizers, how to clean them, and inhalers, and also administration of EpiPen, and make sure that if that's something that's necessary, that is also part of the action plan for that patient. I see that a note that Ashley has a question. I cannot see that question. So, Liza, if you're able to see that question or unmute Ashley, be happy to answer it at this point.
This is Ashley. I don't have a specific question. I was just saying that the email address previously wasn't showing up to everybody. I don't think. At least it wasn't to me.
Okay. Well, thanks for posting that. And, if there's anything else you need, let us know. So for all of you, are you ready? This is a new action item for this Pediatric Learning Network for this lesson. The idea is to plan and test the creation, or it may be the update, of an asthma action plan by using shared decision-making tools and techniques with the next school-age patient who has an asthma diagnosis and their caregiver that you see in your practice. If this is something that if anybody's already done this as a transformation test as part of your transformation work, let us know, because we want to be able to learn from each other. So if you can share right now how that's gone for you, so others could learn from it, that would be great. Anybody? If you do, raise your hand or just. Okay. Well, on the next slide, again, remember that the work that we're all doing together for a practice transformation is quality improvement work. not research. So it's about planning a small test of change that's related in this case to shared decision making, and measuring the outcome, how that goes with the next patient and family that you see. As part of that feedback, don't forget, ask the staff how it went, as part of your team, because you may be doing the asthma action plan and the decision making a little differently than previously, and ask the patient and family, how did that go for them, and how did they feel about their experience, and what else would they like to see as part of that? What else would they have liked to have been asked or had an opportunity to participate in? The other reminder on the next slide is that, as I've said, this is a team sport. So really important that as you're doing this transformation work and testing, and especially as part of the learning network, that you use your team members and include patients in addition to the parents and caregivers as part of your team. Next slide. So if we have an opportunity to make sure everybody's unmuted, and based on the last 3 months of us coming together and meeting and talking and my sharing with you information about how to better improve your engagement with patients and families, any of these type of strategies that we've talked about the last few months, if you can, share some of your experiences with us, please just, speak up. No, I don't have it. I saw from those of you who returned the survey, the few survey questions that were asked of you, that there is some work going on related to these strategies, and we'd love to hear a little more detail if this is any of these are things that you've tested recently or have implemented because of previous testing. Don't be shy. This is the learning network. That's how we, by sharing, we learn from each other. There are no right or wrong answers.
Ruth, this is Diane, and although I don't have something to share, I do have a question about assessment of health literacy. Can you remind me, did you provide some information about how to assess health literacy? Is there some information on the website that I should look for?
Yes, there's actually 2 versions of a very well done toolkit on health literacy that has been posted. And if for some, you should see it. If for some reason there's any difficulty seeing it or downloading it, let us know.
Great, thank you.
Sure. Has anybody had a chance since last month to download that health literacy toolkit?
Doesn't map to your computer?
Okay, well, sounds like there's, opportunities for improvement if these are things that are still on your list to do. We're please, even during the month, if you would like some, if you're bashful and you don't want to talk, as part of this group, but you would like to have a conversation with me to be able to talk about what you're doing or to get some other input, please feel free, reach out to me directly and or to Liza, and we'll make arrangements to do that.
Ruth, this is Liza. One of the things I noticed in the survey responses, the folks who gave us some follow-up feedback about what they've been doing, is that a lot of the participants, or a number of them, are practice coaches or practice facilitators. Is there anything you would do to sort of translate the information you've provided for clinicians to coaches who have to spread it across multiple clinicians? Are there things that are sort of big picture messages that you would try to pull out that the coaches should use?
Well, I think that the idea is, I mean, what I've shared are the types of strategies that, as a facilitator or a QI coach, a transformation coach, that you would focus on with the team. So it's the opportunity for the facilitators and coaches to sit down with the team, whether it's virtually or in the same room if that's possible. I mean, to just really carve out a small amount of time, and then to be able to listen to the team and how they're and guide the team's interaction, to be able to make sure that the idea or the strategy that they identify as wanting to test, that it's small enough, and that they actually are using the PDSA methodology to kind of plan out what that is going to look like. So that would be my advice to how those facilitators and coaches on the line, to be able to, these are the strategies that I find when I do that, is to be able to just kind of guide or listen to and help the practice team identify what they want to plan to test. And then to be able to make sure that, that you come together and do the rest of the cycle after it's actually, the do part is done, to be able to kind of move forward from there, and see how that goes.
And I know the Institute for Healthcare Improvement says these tests of change can be very small. So like one way to make it more accessible to really busy clinical practice is to try very small things incrementally that might make changes both in the quality of care and their response from patients and families.
Right. It can be as small as the next patient you see. You can learn a lot from one patient. And then, so again, just being able to not have everybody testing even the one patient, but to have one team, maybe a provider and an MA, or the nurse practitioner and the MA and front desk staff. As part of the plan, what has to happen is totally going to be determined by what's going to be best for that individual practice team. And then share it with each other, because that's another role of the facilitator or coach, is you can help share that information from practice to practice as you're working, to kind of encourage, what each of the practices is working on. So you have the opportunity to say, so will you share, Voice Pediatrics, will you share with this other team, this other network member, what you just did, what you just tested regarding shared decision-making and asthma action planning for asthma action.
Mm-hmm. And Ruth has presented a portfolio of evidence-based tools that are being used in practices, but you may need to help the clinicians or your own office decide which tool to use, which action plan works for us, or how do we be a part of a registry. And those are places where you might even also bring in patients and families to ask them, sort of looking at this action plan model, does this make sense to you? So, for those of you who are part of the TCPI and are thinking about how are you implementing those measures, the person and family engagement measures that we looked at earlier in this session, asking patients how you're doing and asking patients which tools work for them are ways to kind of meet multiple of the measures, and also asking questions about how the medication management is going. Right. And that's one of the things that Lucy just pointed out this afternoon, is that they engaged their advisory groups in the materials that they were using, the action plan and the other patient materials, to get that feedback, to see what would work and what wouldn't. And again, your tests of change in a practice team, you may find that you want to test one plan, and if it doesn't work well for you, there's a lot to learn from failure. Don't be afraid to fail.
because you may then say, well, let's this plan has triggers on it, and it's also very important that we include that in our discussion for planning and care management. So you may want to test the use of a different plan. Again, it's up to you, and the testing should be done under all different types of situations. It's summertime, staff is out right now on vacation, so that this is a time to see when you're short-staffed what works, just as important as when you're full-staffed, because those are different scenarios. If you're an organization where you have residents and students, what impact does that have on the shared decision-making for asthma planning when residents are involved in those visits? Think about all the different situations in your practice or your organization that need to be tested before you move to implementation. Okay. So this is just, again, a reminder of the assignment for this month regarding testing the use of shared decision-making with the next school-age patient that you see with an asthma diagnosis and their caregiver. I really, really would encourage you to join us next month and just, very informally, very briefly, just be prepared to share what you learned from maybe even your first test of change. And then that's going to be on August 15th. Same time, same place. We're going to be focusing on e-tools as part 3 of our engaging patients and families at the point of care. Here you have my phone number and my email address. Please, don't hesitate to reach out to me if there's anything I can do to you if you're a provider or facilitator or coach to help work with this great and important work that you're doing.
And before we go off of the issue of assignment, this is Liza, I'd like to really beg and request that you respond to that little survey link that I sent out with the reminder yesterday. It really gives us important information. On our next call, we'll provide you some feedback with who's been on these calls and what are their what are the actions they've taken and what are some of their challenges. So it would be really helpful to us if you'd be able to do that brief survey. And as Ruth just mentioned, she is available for one-on-one coaching. We'd be delighted to have her contact either you or me, and we can set up a call for you to kind of jumpstart your work at the clinic level. And for any of you who are interested in following up on any of the resource material, my colleague Jacinta just texted out the website in the chat boxes, and it's also here on the web page, the main TCPI website that has our person and family engagement resources, and then the specific lesson plans and resources from our pediatric asthma work. And on that asthma page, you have to go down to the bottom of the page and choose the lesson plan, and you'll find the slides from today and the other resources that Ruth showed.
Great, thanks, Liza. Any final concerns, questions? Well, we appreciate your time today. Again, a special thank you to Dr. Maurizio for sharing the great transformation work that's going on in her network and at CHOC to reduce ED visits. Hopefully, I'm sure that the other pediatric practice transformation networks, are doing similar work, and hopefully we'll have similar successes. And if you'd like to share what you're doing in your network on another call, please let us know, and we would love to highlight that.
Thank you, Ruth. I think we'll adjourn, and we appreciate everyone being on the call. We hope you can join us next month.